Thank you very much, Mr. Chairman. Ladies and gentlemen, we are going to address in a few slides a very delicate topic that is the long-term result of sleeve gastrectomy. As Professor Scopinaro was mentioning this morning, many operations are performed without knowing the long-term results, and one of these operations was sleeve gastrectomy, that is, as many as you know, one of the most popular operations these days. There are a few papers addressing the long-term results, and I would say that basically pertain to a time of the experience where we did not know very much about the technique and the complication. This is the classic paper from Jacques Pence, where you can see very clearly that there is a quite constant weight regain after sleeve gastrectomy as a standalone procedure and sleeve gastrectomy followed by duodenal switch. And as we were mentioning this morning, all the operations have some weight regain during the years. So Jacques Pence clarified very nicely the results, and he also mentioned that one of the possibilities was the enlargement of the fundus, and the question was very debatable. Is this was a neofundus, a part of the stomach that became enlarged after the operation, or part of the stomach that was left there at time of surgery? Now, our technique of sleeve gastrectomy are more aggressive, especially on that area of the esophagogastric junction. A very nice study was recently published collecting all the papers that have been presented in the international literature on that topic. And this is a British meta-analysis from Professor McMahon from Leeds. And you can see quite clearly as basically he claimed a quite stable percentage of excess weight loss over the years. When you go and analyze, in fact, the number of experience and of the published paper, you see that the number remain very small with a follow-up that is not very high. The conclusion of their study was that the weight loss at the end of the first year was very much predicting the long-term outcome of this operation for that given patient. But of course, further study and investigation are required. Another very interesting paper was published by Seischer. This paper was comparing a group of patients that had a primary sleeve gastrectomy with a group of patients that had sleeve gastrectomy as a revision operation following gastric band. As you can see, up to 5 years, according this experience, although the primary operation have a better response to surgery, they still remain in a good range of weight loss. And a similar remission improvement of comorbidity was achieved for all these patients. The paper from Peterly also discussed the possibility of GERD remission and new reflux that, as you know, is a hot topic at that point, because it is quite unusual that we are going to perform an operation and a procedure that should be resolving both the morbidity, obesity, and GERD. So they clearly support the opinion that people with severe gastroesophageal reflux should receive a Roux-en-Y gastric bypass. This is the classic paper from Shower that also proved the benefit of sleeve gastrectomy on remission and recurrence of diabetes over the years. This is a paper with a limited insight into the sleeve gastrectomy, but basically they conclude that certainly in general diabetes mellitus can be addressed by bariatric surgery. And this is another large review that show the way the weight loss is achieved with sleeve gastrectomy. When you go and after the 6 years, you see that the number of the patient remain very small. And I can tell you from my own experience, I will address this topic in the next few slides, that there is definitely a number of patients that develop weight regain. I go, in fact, now straight to my own experience. As you can see now in my experience, sleeve gastrectomy is the operation I prefer in my practice. So we analyze data on 105 patients operated by myself, and we divided by group. One group was the morbid obese, and group 2 was the super obese. And you can say that with the exception of BMI, the other parameters were quite comparable in terms of comorbidity and sex and age. And you see that it is quite important, if I may address to people are doing their practice, to have a meticulous and aggressive follow-up of the patient they are operating. In fact, I have, as I was taught by Professor Scopinaro, a secretary, a bariatric coordinator that is totally dedicated to follow up patient. Occasionally, although Naples is a small area, we have secret investigator, personal investigator, and mafia people, if it's needed, to collect the data of the patient. What happened is that we reviewed our experience, and we had that basically 90 patients were followed up at 5 years, and 9 patients had a revision. Basically, patient had the revision surgery at the Roux-en-Y or duodenal switch. One patient had total gastrectomy for cancer, and one other patient had a crural repair and a mesh placement for hiatal hernia recurrence. These are my short-term complications: early gastric stenosis, acute tubular necrosis caused by dehydration, and this was in a diabetic patient that suffered also 2 days of intensive care unit to recover from dehydration. That can be a terrible problem in sleeve gastrectomy, and one patient required blood transfusion. These are the data showing in the red, in the group 2, of course, the result in super obese people, and in group 1, the result in morbid obese population. This is very clear in my mind, and I thought it was very important to show you and to share with you this data, that in my own experience, if you do a sleeve gastrectomy with somebody with BMI less than 35, first of all, you should have quite clear in your mind that your success rate should have a BMI, the patient should have a BMI at, sorry. Oh. So to have a success rate, you need to have a BMI less than 30 in people with a BMI less than 35. And in this setting of patient, BMI less than 35, my success at 5 years is 100%. If you consider the morbid obese, where the success rate is considered if you obtain a BMI less than 35, my success rate is 85%. In the super obese, my success rate is 62.8%. It means that if in Naples a super obese patient come to me to have sleeve gastrectomy as a single operation, that given patient has a 40% rate of failure. That is quite high, and this, it means that that patient needs a second operation if we want to achieve a decent success in weight loss. In the morbid obese people, I think the success is much higher. You have 85% success. When we talk of diabetes, I was really surprised by analyzing my data because the success rate we had was very, very high. But as you can see, these people did not came to me for diabetes. They were obese, and during the study I found out that they were also diabetic. In fact, 2 out of 20 patients were not even treated for diabetes. 16 out of 20 were on metformin, and only 1 patient was on insulin treatment. So my percentage of success was very high. As you can see, 90% of remission and only 10% of failure in those who didn't change very much their weight loss. But very important, I found in my series that the excess weight loss of diabetic patient was significantly lower when compared to non-diabetic patient. And this is quite strange, Professor Scopinaro, from your observation, that diabetic patients lose more weight than non-diabetic. Regarding the GERD, the gastroesophageal reflux, you can see that, as I showed you this morning, there is definitely a good percentage, 64% of patients in the morbid obese that get rid of reflux in the morbid obese population, while the results are less successful in the super obese, because super obesity probably is a condition that create a much worse symptoms than morbid obesity. I mean, the weight increase create more symptoms on the esophageal reflux. And here is the example of those patients I presented to you this morning, that although they had a Roux-en-Y, they still remain with some reflux symptoms. So in conclusion, sleeve gastrectomy maintains a good weight loss outcome at 5 years, with a mean excess weight loss of 55%. But this is a versatile operation with satisfactory result in patients with different BMI ranking. But it is quite obvious that the strategy for weight regain remain controversial, and we need to absolutely to address the point of what we do when a patient in morbid obese or super obese population regain weight. And this is one of the topics I'm going to address in this course in Naples in April. We are going to perform live surgery. We will do duodenal switch, SADIS, standard BPD, all the operation done as a revision of sleeve gastrectomy will be performed. Thank you very much for your attention.